last time, and at least we've got some idea what we're getting this time. Or secondly, because it was one of the best things you've ever heard. So I'm not going to ask you which was the reason you asked me back. But if you're rubbish, nobody ever asks you back. So that's at least a positive thing. Okay, I'm going to share my screen to start with. Let's go for that one, shall we? And we're going to talk about urinary continence after the treatment for prostate cancer. Okay, so for those of you that don't remember, I'm sure most of you at the previous meeting, I was diagnosed 12 years ago at the age of just under 60. I'm 72 now. I had what by today's would be called very minor disease. I probably wouldn't be treated at all. I've probably been grossly overtreated. In those days, I had the option of either having surgery, of having external beam radiotherapy, or it wasn't called active surveillance then, it was still called watch and wait. For me, there was a knee-jerk reaction. I've got a cancer, let's cut it out, let's get rid of it, which is a very common thing, I think, that many men actually go through. In retrospect, and by today's standards, like I say, I would never choose surgery for the degree of severity of my prostate cancer, but you do what you do at the time and you cope with what you've got. So I don't know how many of you are the previous meetings, but we always start with a bang, and today is no different. It may seem just a little bit familiar to a few of you.
It's live. It's Strictly Come presenting.
So that may have been just a bit familiar, the tune and the presentation. There is another one, but we can do that another time. Okay, so because I'm a doctor, yes, I do like anatomy, I do like physiology. Equally though, I really have a great belief, and I think it's a genuine opinion. If you know how your body works, even in very simple terms, then you can understand what goes wrong with it. If you understand what goes wrong with it, then you can understand the sort of treatments that may be offered to you. And even more importantly, you can understand why certain treatments might not be available to you or may not work for you. So unless you know a little bit of how things work, I'm afraid it makes it very difficult. And it always upsets me to an extent when you talk to patients and they really don't have a clue about what's been told to them and why a particular treatment may or may not be for them. So we're going to talk a little bit of very simple anatomy. We'll take you through a Boy Scout's guide to the physiology of incontinence in a wee while. Important statement, and it's probably going to be obvious to you guys, but incontinence isn't the same as frequency. And people sometimes get terms very, very confused. Frequency is all about how often should you go to the loo, how many times in the day, how many times at night. And if you're giving awareness talks about awareness of prostate cancer, you will undoubtedly be talking about frequency of passing water, particularly at night. With incontinence, very often it's a habit, because you're worried about leaking that increases the times you go to the loo. So it's more sometimes as a preventative measure than others. We classify incontinence in a number of different ways. There's what's called urge incontinence. There's stress incontinence. There's overflow incontinence. There's something called climacturia, or incontinence with orgasm. And there's a mixture of all of those. So urge incontinence is, I'm sure you've all experienced it, or many of you have, an overwhelming need to pass water. You've got to go now, you can't hold it. I had that sensation in spades for, gosh, at least 2 years, and I chose to ignore them, but that's another story. It's very common with prostate enlargement. It's often made worse, or often called having an irritable...
What do you think I should do then?
Or a hypersensitive bladder. So what causes urge incontinence?
We ain't going to be back.
Well, you've got to look at the anatomy a little bit.
How can I do that? Why didn't you tell me to do that?
I think somebody needs to turn their mic off.
You're back on, Stephen.
That's fine, thank you. Okay, sorry.
Yeah, okay.
Right, let's go where we were. Fine. Okay, so let's look a little bit at your anatomy. It's a bit complicated. Let's make that just a bit bigger. Why? That's good. So you've got the bladder. The bladder is basically a bag of muscle. Many people feel that the bladder is a very thin, flimsy little structure. It's not. It's actually quite a big and beefy sort of muscular bag. There's the bladder neck where the urine comes out, down through the urethra, down through the prostate, then out through the urethra and through into your penis and out to the outside world. The urine comes from the kidneys through the ureters and arrive in the bladder through two little openings at the bottom of your bladder called the ureteric openings. Now there's an area below that which is quite important. It's called the trigone because it's triangular in area. What is the function of this? Well, this area is the thing that tells you need to go to the loo. This area is full of stretch receptors. So as the bladder fills up, it stretches this area. Those stretch receptors get stimulated and it sends a message to your brain, your bladder is getting full, you need to pass water. Anything which, if you like, artificially stimulates that area will produce the same sensations. And the commoner thing that happens is that your prostate gets bigger. So it bulges up underneath your bladder and it starts stimulating that trigone area. So your enlarging prostate stimulates the trigone and keeps telling you you've got to go to the loo and you've got to go now. So it hypersensitizes that whole system. In the same way, recurrent urine infections, things that have increased and irritated the inside of your bladder, also send messages to the brain to say, you've got to go now. So basically, you're being told that you've got to go to the loo when your bladder isn't that full. So urge incontinence is all about false messages, if you like, going to your brain. And you can, to an extent, override those false messages with negative feedback, with CBT. People that have got irritable bladders can be trained to try and overcome those sensations. Stress incontinence, many of you will know about. It's just leaking with increased abdominal pressure. When you're coughing, when you're moving, when you're sneezing, when you're exercising, getting up and out of the chair. And it's all about your pelvic floor. Your pelvic floor is this huge bit of muscle. It's not, as you think, a gentle little bit of thin muscle. It's a whacking great set of muscles about 1 centimetre thick. If that muscle tone is less, and it will be after surgery and after radiotherapy sometimes, everything drops down a bit and your urethra doesn't have the nice bend in it should have. So you're much more likely to leak with pressure, increased pressure. And at the same time, we'll talk about them in a minute, but your bladder sphincters, the muscles that keep your bladder shut, are also affected and can produce stress incontinence. Overflow incontinence is a very different thing. Overflow incontinence is all about when your bladder is full. I'm sorry, this is a female picture. I couldn't find a decent male picture, but imagine there's a prostate here and that's obstructing the outflow of your urethra, of your bladder. When you empty your bladder, if you've got outflow obstruction, then you very often don't empty the bladder fully. There'll be 50, 100 mils left there. Next time you go, you still won't empty it fully. So very, very gradually over, can be many, many weeks, men with outflow obstruction gradually increase the size of their bladder. And because it's happening so slowly, your brain gets used to the messages. So it doesn't know your bladder's full until it's really quite stretched. There comes a time when the bladder is as full as it's ever going to get, the pressure builds up and it will overcome the obstruction and it will start to leak. And it's usually just a constant sort of leak. We saw this a lot in older men with very large benign prostates when men didn't seem to know what to do about that sort of thing. And they'd come in with overflowing incontinence, leaking all the time. You'd examine them and they had a huge bladder. They may almost look pregnant. And you'd put a catheter in to drain the bladder and it wasn't uncommon to get 2, 3, 4, sometimes even 5 litres of urine out that accumulated over a period of time. They didn't know about it until they started becoming incontinent because of the increased pressure. So climacturia is leaking urine at the moment of orgasm. And it is, if you like, a sort of combination of stress incontinence. When a man has an orgasm, and we don't fully understand the physiology and all of the muscles that are involved in that, but you very considerably increase your pressure in your abdomen, you squeeze your bladder very hard. Normally your sphincters will cope with that, but if you've got weak sphincters, you will leak urine at the time of orgasm. Because many men will know about dry orgasms, because when you've had surgery, and to a certain extent, the semen volume is reduced after radiotherapy and brachytherapy, but dry orgasms, you still get a very pelvic sensation, but you don't get the urethral sensation, literally of something coming out of your penis. Now, men either like that or, and very often miss it, but we are a very sort of penis-orientated set of people when it comes to having an orgasm. I've got to say, having had major surgery, obviously my prostate was gone, everything else. I would have had a dry orgasm. And you still get, like I say, a very deep pelvic sensation of orgasm. In some ways, it's actually even more intense than the orgasm I would have got before I had my surgery. But because I'm incontinent, because my sphincters are very weak, I leak urine. And I have to say, you can leak urine at very high pressure, and it's a bit like a rampant hosepipe. But what it does do for me is give me a wet orgasm, so I get urethral sensation. And for me, that's actually quite a pleasurable experience. But again, for most people, after surgery, it will be a dry orgasm. Climacturia can occur to an extent even with normal fit young men. The normal sort of semen volume is around about 5 to 10 mils at the very maximum that comes when a man orgasms and a man ejaculates. If somebody tells you they're getting 20, 25 mils, of semen, the likelihood is some of that's mixed with urine because they've got a mild degree of climacturia. And of course, at the end of the day, it's like most of life, after surgery, after treatment for prostate cancer, it's going to be probably a bit of everything. How much leakage is significant? And there are lots of, there are special scales that people use about how many pads per day or whatever. Yes, that's very useful if you're trying to gauge things scientifically. But to be honest, everything is very different to each man. An intervention for incontinence, I believe, and most people do, I would hope, is based on patient needs. There are many men who are quite happy losing 20, 30 mils of urine a day or whatever. But there are equally many men who are very uncomfortable losing anything at all. And it's all about what are your expectations as a patient of outcomes and what can you cope with. So what can we do to prevent post-radical prostatectomy incontinence? And that's what I'm going to talk about in the main, but like I say, incontinence can occur with any therapy, radiotherapy, brachytherapy, but probably not to the large degree that can happen with major surgery. Equally, men having prostatectomies for benign disease, men having a rebore, men having what's called a transurethral resection of their prostate, TURP, they can also get severe incontinence. Very, very rarely is that ever talked about. But the principles are the same as happens with post-radical prostatectomy for cancer. Risk factors, age. The older you are, the less likely you are to have maximal muscle tone initially of your pelvic floor, of your muscle sphincters or whatever. The stage of the disease. Has the cancer infiltrated outside the prostate? Is it affecting tissues outside the prostate? The technique of surgery being used, was it nerve sparing? Was it robotic surgery? Was it very localized surgery? Was it one of these newer techniques, Cave-Retzius technique? It will depend to a certain extent on surgeon's experience, and there is no doubt about that. But there is also a huge variation in the anatomy of patients. And you can do exactly the same procedure, exactly the same sort of thing to two patients and get very different results. Men's anatomy to start with may be different. I certainly had very weak sphincters before my surgery, I think. So again, any treatment for prostate cancer can produce a degree of incontinence, not just surgery. So what's the physiology? Well, we've talked about bladder dysfunction. We've talked about urge, incontinence, irritable bladder, that sort of thing. Pelvic floor dysfunction, I'm sure you know about a lot because the pelvic floor supports the urethra, supports the rectum, and surgery reduces that pelvic muscle function. Really important to do pelvic floor exercises, whether you have much degree of incontinence or not. How to do them is hugely important, and getting specialist advice may well be available to you through the urology nurses or whatever. Two simple ways, of trying to explain if you're doing them properly. It's all about trying to draw up the pelvic muscles inside you. It's not around the anal sphincter, it's at the very front of your body. And I'm sure there'll be a physio who can come and talk to you about this. But two ways you can ensure that you're doing it properly. First way, and one way of practicing, is to sit on the loo with a full bladder, start having a pee, and then stop yourself from peeing. Pull the muscles up inside you, which, sometimes people do anyway. But those muscles are your pelvic floor muscles. Okay. Equally, stand in front of a full-length mirror naked. Look at your testicles. when you're doing your pelvic floor exercises properly, you should see the penis and the testicles very slightly rise in their position, because the pelvic floor is contracting and bringing them in. It's a really easy and very sensitive way of seeing whether you're doing them properly. When do you do them? Really important to start pre-operatively. If you're a very fit sportsman, you're a footballer, then you have a knee operation, you work on your quads exercises afterwards to keep your muscles in tone, but you will have also done that before. Your pelvic floor for your prostate are like your quadriceps exercises for your knee. They need to be done before and after the surgery. Equally, it's important not to overdo them. You can get muscle fatigue if you try too hard. Also, it may improve your sexual function a bit, because those exercises increase pelvic blood flow, increase blood flow to all of the other muscles associated with your pelvic floor and with sexual function and orgasm. So what about sphincter dysfunction? The sphincters are the bits that keep you continent. And you have two. Men have two in the main. There's one called your internal sphincter. Now this, and sphincter, as you know, just means a circle of muscle like your anal sphincter, like your esophageal sphincter. It just closes the tube completely flat down. So the internal sphincter is basically an extension of your bladder wall. It's almost part of the prostate. The two are virtually inseparable. Any form of prostatectomy, and you remove the whole of that prostate, will get rid of your internal sphincter. You will no longer have any internal sphincter function of any note. Even if you're having a rebore and they sort of apple core your prostate out from the inside for a benign disease, they will take some of that internal sphincter tissue with it. So this, basically, for all intents and purposes, is destroyed by radical prostatectomy, and the man then has to rely on his external sphincter at the bottom of the prostate. This is probably the major continence mechanism post-surgery. It's more identifiable to from the prostate. It should be able in most men to be dissected fairly easily free of the prostate. Having said that, however good the surgeon is, there may still be some degree of damage to this external sphincter, some bruising to the nerve supply to that sphincter with the surgery, whatever. So the bottom line is that you may well have a reduced efficiency of your external sphincter for a period of time after surgery, even if it's not been severely damaged. Excuse me. And everybody, I'm sure you know, will have a period of incontinence after surgery. This may well be as little, the shortest I've ever known a man was about 4 days, and he was totally dry. He was young, he'd had robotic surgery. At the other end of the scale are people like me who were totally incontinent. And people like me probably had very little in the way of an external sphincter anyway, naturally. We were relying preoperatively entirely on our internal sphincter, which has gone. So what I ended up with is no sphincter at all. So no control, no obstruction to that outflow. So surgery will try to preserve all or part of it. If part of it is damaged, then muscle will regrow, it will recover, and so will its nerve supply. But it will depend on the degree of muscle damage. It will depend on the degree of muscle dysfunction. Talk to people who've got severe incontinence, and that's often a comment that you get. It's strange, but I'm not too bad at night. I hardly leak at all when I'm lying down, but as soon as I get up to go to the loo, it just drops out of me. I leak horribly. And that is very typical of a man with severe sphincter disturbance. There he is, lying on his side, and lying on his side is like a half-empty wine bottle. Doesn't have a cork in it, but because the fluid level is below the outflow, he doesn't leak. The wine stays where it is. When you go upside, stand upright, unless you've got a cork in this bottle, then it's all going to fall out. And that is very typical of severe sphincter dysfunction. So what can we do to manage incontinence? I'm not going to spend a lot of time on this because I'm sure most of you know that already. It is important to seek some specialist advice. Every hospital should have a specialist incontinence service. That may well be a community service to come and tell you what devices, what things you can have, ordering equipment, allowing you to get pads on the NHS if that's what you need, all of that sort of thing. Pads and pants come in all shapes and sizes. They can even get them, I believe, now in duck egg blue for men. The convene system is basically, if you don't know it, is basically a sticky roll-on condom with a valve, a spout at the end, which then goes onto a leg bag on your leg. Allows you to drip urine constantly and not to be wet. There are various other hideous collection of things that people have tried to market. I have seen quite a lot of these online when I've been researching, but I've never known anybody use one. Penile clamps put the fear of God into most people. But in the right usage, they can be incredibly useful for people. Certainly, one of good friends now through my own support group, he used a convene for most of his time. It was fine. He was very lucky. He had a villa in Spain. He went out there a lot. He was able to cope with just slightly longer shorts than normal because he could put a very short tube leg bag on, smaller leg bag. Nobody seemed to know. But he was a granddad. What he really, really wanted to do was get into the swimming pool with his grandkids. Yes, he could sit around the pool, he could play game, he could do anything, but he didn't feel he could get in the water. That's when a penile clamp became a godsend. He could take everything off, put a penile clamp on, he'd then wear a normal pair of swimming shorts, and he'd be in the water, not leaking, up to an hour. It's about the length of time you're meant to put it on. So all of these things should never be totally disregarded, even if they're not for you, but used in the right context. They can all be absolutely life-changing. Yes, there are interventions for prostatectomy incontinence. You can bulk up the internal sphincter with urethral bulking agents. You can put slings in, and you can have an artificial sphincter. And the choice will depend on how severe your incontinence is. The idea behind bulking up the bladder neck, and they use collagen normally, is basically to mimic the internal sphincter. So if you look up a cystoscope, that's what you'll see with a chap with no internal sphincter, looking straight into the bladder. There's no muscle keeping the bladder neck shut. So gradually you inject, usually silicone, until you've artificially closed it off. Now that will not withstand huge pressure, but it will withstand the pressure of somebody standing up with, let's say, a half-empty bladder. It's not that strong, but it will produce quite a significant change in mild incontinence. It's easier to perform. It doesn't burn any bridges. If it doesn't work, it doesn't work. Its disadvantages are it's not permanent. The silicone gradually gets resorbed. And as far as the NHS is concerned, to a large extent, it's not cost effective. And for many men, it doesn't work that well. The people that I've talked to that found this really useful are people at the very beginning of their journey with incontinence. when it's taking a long while, perhaps muscle function to return. And they've had some collagen injected last 3-4 months perhaps, but by the time it's gradually got resolved, their own muscle function is beginning to return. So it's probably not sensible as a permanent cure for long-term incontinence. But again, used in the right context, it can be good. Slings basically try to mimic a little bit of what your pelvic floor's doing. Slings are going through very bad press at the moment, particularly, as you've probably heard on the news, for women who've been having all sorts of chronic pain problems. The mesh that's used, the devices that are used for male slings can be the same as those, and they're no longer being used, but there are other materials that may well be used. But at the moment, my understanding is that pelvic slings are not being done that commonly. The artificial urinary sphincter is the gold standard. This is what will deal with the worst form of incontinence. And it's really simple. Think of a blood pressure cuff, miniaturize it, put it round the bottom of your bladder, round the urethra. And it could be anywhere from the very bottom of your bladder almost to the scrotum in the perineal area. That's filled with fluid and it's under pressure, and the pressure is kept up by a reservoir, which is basically a silicone balloon. In your scrotum is a control pump, and this is what I've got. So I now have a bionic third testicle. When I want to go to the loo, and my bladder is normal, I get normal sensations, it's just that I leak. When I want to go to the loo, I squeeze my bionic third testicle, making sure it is the right testicle I'm squeezing, and that releases the pressure in the cuff. That allows me to pee quite normally. I've got normal bladder function. Over the next 2 to 3 minutes, this pressure reservoir fills the whole system back up, so the cuff reinflates, acts like an artificial sphincter, and stops any further urine. For me, it's changed me from being, well, I was about 99% incontinent to now being 96% continent. I don't think about it anymore. I'll climb ladders, mow the lawn, do whatever I want, exercise, whatever. I don't think of it at all. That's what it looks like. Give you some idea of size. That is about 1.5 centimeters long. So it's a biggish structure. There's a different one, which is a 2-piece system. It's got a much bigger control valve. I've spoken to 3 men who've had these put in, and they weren't as happy as the other device. There are things you have to think about. It is a two-handed job. Your testicles, and indeed your bionic testicle, is mobile. So you've got one hand has to hold it still whilst the other one squeezes it. It works best if you've got what's euphemistically called a quiet bladder, not one that's overactive, not one that's giving a lot of frequency problems. You can't have one fitted if you've got anything wrong with your urethra. It squeezes your urethra. It can decrease the blood flow. So people with getting regular strictures, it's not recommended for. Or if you need regular transurethral surgery, you cannot be catheterized once the cuff is inflated. To be catheterized, you must decrease the pressure in the cuff. You must let that down. So I carry a card in my wallet. My biggest fear is that I should have a major road accident, be unconscious, come into casualty, and they'll try and catheterize me. They won't be able to do it. They will just damage my urethra. Infection isn't possible because it's a foreign body. But its advantage is you can have it after you've had a pelvic sling put in. If a pelvic sling hasn't controlled things well enough for you, you can still have one of these fitted afterwards. A pelvic sling would not be taken out. They'd just put it, because you can put it anywhere down the urethra, they just put it in a different place to your pelvic sling. So the recommendations by the powers that be is to wait 12 months. before anything is done. And an artificial urinary sphincter is the choice for severe urinary incontinence, then a male sling, and then possibly a bulking agent. I've got to say, I think this is entirely wrong. Certainly from my personal experience and talking to lots of other guys with pretty severe incontinence, what you've got at 6 months, I'm sorry, but it's probably what you're going to get by 12 months. And my advice to anybody, particularly because, I mean, sphincters are available on the NHS, but they're not done in every hospital. I would start saying to people at 6 months with severe incontinence, I want to start going down the road of getting investigated further. I want people to start thinking about what I can have done and what I can't have done. Because by the time, you know, you've come to 12 months, it'll have taken that time anyway. So start early is my motto. So my story, you've more or less heard. I had a radical. I was really doing well until after the catheter came out. I can still remember the day I realized I was going to be incontinent forever. And I was standing in the bathroom having a shave. I was naked. I looked down and I could see I was in a pool of urine. I'd been leaking. I hadn't even realized. And I was totally devastated because I was only 4 weeks after my operation. I thought my operation had been successful in removing all of my cancer. And now it looks as though I'm going to be incontinent for the rest of my life. And it was just after my 60th birthday. So I saw my guy very soon afterwards, and he was absolutely devastated as well. It was the worst case of incontinence he'd had for many, many, many years. He was a really good surgeon. And the morals of that is never operate on a friend, never operate on a doctor, because it always goes tits up. But basically, he said nobody would do anything for a year. That was just dreadful. I had no idea, no understanding how continence was such an important basic function of life. We take it for granted, but it's a huge, huge basic function. To be honest, I would have coped better if I'd gone for my follow-up and they said, look, Steve, I'm really sorry, but there's a couple of bits of cancer just in your pelvis. We need to zap that with a bit of radiotherapy. Do I think I would have coped with that easier? Because it had an end point. It was something positive. You know, a few sessions of radiotherapy and my chances of a further recurrence may well have been very, very low. I was being told you're going to be incontinent for the rest of your life. I had a 3-year-old granddaughter, I think it was at the time. She was being very proud and coming and telling you she didn't need to wear nappies at night, and she was a good girl. Her granddad was just wearing them, and that was mind-blowing. I saw my incontinence nurse. She came to my house. I gave her a really hard time. I was not in a good place psychologically. She talked about pads, and I thought, how wonderful, I need to wear pads, and I need to wear tracksuit bottoms and loose trousers for the rest of my life. What a wonderful thing that is. And I wasn't having that. She mentioned the convene system, and that didn't really appeal very much either. Wearing a bag for the rest of my life. I was 60, didn't want that either. We talked about penile clamps. She was very dismissive of them. As I say, I've learnt from other men rather than the incontinence nurse how valuable these can be. We talked about pelvic floor exercises. I went and saw a specialist in pelvic floors, lady down in, near Weston-super-Mare, Taunton. I had a brilliant pelvic floor. My pelvic floor was rock solid, but I was totally incontinent because I had no sphincters. So how did I cope? Well, and how do I still cope? I've got a big ego. I'm going to be totally honest about that. I was not very fit, but I used to go to a gym and go swimming. I wanted to go back to that gym where everybody changed together. I certainly wasn't going to change in front of 20 other men and show everybody I've got a bag on my leg. I wasn't going to go around the gym with a bag on my leg wearing shorts. It was really important to me to look normal. The best option was some sort of pad. Now, tenor for men, I'm sure most of you have used them. I think they're bloody awful. They are big, they're bulky, they're huge. That's somewhere up around your umbilicus. That's a big pat wad of stuff between your legs. And that's where you need it. You don't need anything up here because your willy points downwards for most of its life. And that's where all the urine's going to drip out. But they're big, they're bulky. So what did I do? I went to women's pads. Women have got a whole range of size, thickness, absorbency. They've really got that sorted. I happened to find that a woman's pad fitted in the underwear I currently wore. And it was these Calvin Klein brief things. And they're designed with a little sort of pouchy bit in the front. And a women's pad fits brilliantly inside there. Yes, they're small. Yes, they can be quite absorbent. But yes, for me, they worked. I needed to change them very often. I would need to change a small pad 6 or 7 times a day because I wanted to ensure I never got into any sort of leakage problems. So it was an expensive option. I was happy to pay that. It was worth it for being normal. And I want always to be normal. The only accidents I've had have been my own fault, really, where the pad hasn't been in the right place or whatever. I was advised when people started talking about incontinence, you've got to give up caffeine. You should really be giving up alcohol. They're both irritants to your bladder. Caffeine is a diuretic. So yes, I religiously for a whole month went to decaffeinated coffee. I gave up any form of alcohol for a month. And the only thing that was irritable after all that was me, because I do like a good strong cup of coffee and I do like a glass of wine or two. And to be honest, it had made absolutely bugger all difference to my incontinence. So I thought, nuts to that for a game of soldiers. I'm going to go back to having a normal life. So, do beware of the muscle relaxing properties of alcohol. The only 2 major leakages I have had, and I have to say the only times that my wife has had no sympathy for me whatsoever, has been when I leaked because I drunk too much. And I can remember both of those very embarrassing situations. Yeah, you learn and you move on. Exercise is also important. It keeps you fit, keeps your pelvic floor fit. So I tried to go, it doesn't matter what exercise you do, keeping yourself generally fit is good. Do you know what the best exercise is for the newly incontinent? Yes, pelvic floor exercise. What general exercise? Well, in my opinion, it's swimming. Swimming, yes, it exercises lots and lots of your muscles, but even more if you're incontinent and you leak, nobody knows. And I would go swimming. I would make sure I started with an empty bladder. I'd swim. And because I was horizontal, I didn't leak very much. And to be honest, if you're swimming in a 25-meter pool and it can't cope with perhaps 10 or 20 mils of urine leaking out of somebody in the middle of the pool, you shouldn't be swimming in that water in the first place. It must be rank. So for me, I think it's the ideal. The only time I would leak a little bit, and it wasn't much because my bladder was empty, would be when you got out of the pool and you stood up. And of course, water's dripping down your legs and everywhere. So nobody knows at that time either. And I would just go immediately to the poolside shower and make sure it all got washed away. So for me, it was an absolute godsend, absolute revelation. We've talked about pelvic floor exercises, and it's important also to set targets for recovery so that you've got something to aim at, something that you want to achieve. I had, before my operation, for my diagnosis, I'd already agreed, and it was going to be 3 months after my surgery, to go and give a talk out in South Korea. I hadn't been asked to go and give talks abroad very much. And it was a real opportunity for me. And I wasn't going to give that up. So I went to South Korea with lots of pads. My biggest problem was not being worried at talking in front of an audience of about 400 inscrutable men from the Far East. That didn't worry me. What worried me is if my suitcases got lost, how am I going to sort out having enough pads to last me through 4 days in South Korea? But we did it. We sorted. It was fine. And it's really important to set, to be positive. And how do you know when you've really succeeded managing incontinence? Well, the answer is simple. It's when you start wearing light coloured trousers. And that, I know, is as trite as anything, but it's true. I was very confident that I wouldn't leak, and nobody, if I did, because it shows on light colours. Dark trousers are fine. But I knew I cracked it when I started wearing it. And indeed, when I went and saw the physiotherapy lady, her first comments when I walked into the room were, "You must be doing well. You're wearing light coloured trousers." And I thought, that's good. My outcome, as I've told you, I was virtually incontinent 9 months afterwards, and I had the artificial urinary sphincter fitted. I've got to say this has been an absolute godsend. How did I cope with severe incontinence? And of course, you get erectile dysfunction, which we can't talk about today, but we can talk about perhaps at another time. How did I cope with all of that? Well, the first thing I did very early on was I went and saw a psychologist. As I say, this incontinence, and to an extent, certainly erectile dysfunction, just floored me completely. It wasn't something I'd been expecting. I wasn't in a good place. Because of the work I did at the hospital, I worked with psychologists in my chronic pain clinic, and I went and saw somebody there. And the phrase I always used to use to my patients, and I think it's a really good phrase, is to go and talk to a professional stranger. Yes, you can talk to family, you can talk to friends, and they can be very supportive and very helpful. But sometimes you may say something to one of your friends or your family that you regret. There may be things you don't want to tell your wife or your partner or whatever, but they need to be said. Go and see a professional stranger. If you say something to them that you regret, or you don't get on with them or whatever, you just walk away from it. They don't care. They don't mind. They're trained to deal with whatever you tell them. And I had 4 sessions. First session, first hour, I did nothing but alternately either shout or cry. That's all I did. It was just a wonderfully sort of cathartic way of getting rid of emotions I couldn't have done at home. Then we had a number of sessions together where we talked about management. I don't know what we talked about. Now, we certainly didn't talk specifically about either incontinence or erectile dysfunction. It was all about coping. It was all about life. It was about me. And that was hugely, hugely important. I joined a support group like you've got, and being able to talk to people was really good. And, getting advice, getting contact with people in a similar situation is just totally invaluable. I became a volunteer with Tackle and Prostate Cancer, and through them, I've met you guys. I've met huge numbers of people. And I now, when I talk to other people, very much rely on the enormous experience I've gained from being involved with both of those charities. And yes, I talk a lot. You all know that. That's something I'm quite good at. But it's so important to share information, to share your experience. I'm very open. It doesn't worry me to be open. Maybe my medical background, I don't know, but I've talked on LBC radio very, very, very frankly about erectile and sexual dysfunction on one of their programs. And yes, it is a cathartic experience, but you've got to be very careful that you don't use it as your own therapy. And that's what sometimes worries me about people that spend a lot of time on chat rooms and Facebook pages and whatever. Very often it's for their own benefit and not for the benefit of the people that they're trying to help. And I couldn't have done it without my wife. Like I say, the only time she's not been supportive is when my incontinence has been her problem. Been my problem rather. I am slightly worried now. The average life of survival of an artificial urinary sphincter is said to be 10 years. I'm already in my 11th. My 11th year comes up in August. It's going to fail at some stage, but we do know that it fails slowly. It's usually the elasticity of the reservoir. Gradually the pressures go down and every bit of it can be replaced. But it just totally revolutionized my life. So that's my experience. That's my ideal of how to manage incontinence. I shall unshare my screen. As I say, if you ask me any questions, trust me, I'm a doctor.
Well, thank you very much, Stephen. Can you hear me?
Yeah, I can hear you. You
Yeah.
probably need to unmute everybody now, Richard.
Yeah, okay. I think we're okay. But yeah, thank you very much for your honesty. I mean, you can just learn so much from what you've been through. And I think we've all been through similar or different things. But your experience is just so incredible and very inspiring to hear what you've had to say. I don't have any questions, but just thank you very much for sharing all that information. It really gives you a lot of hope. So thank you.
I think that's the important thing, Richard. There is always hope. Men should never be told it's something you've got to put up with. There is always something which may improve your current situation.
Yes.
It may not cure you. Nobody's going to tell you there's a cure for many things.
Mm-hmm.
But it's all about how do you cope better. And it upsets me, not annoys me, when you hear of patients who nobody's talked to them about it.
Well, that is the problem. Yeah, people don't talk.
No.
But listening to you and your experience, I mean, yeah, we can all relate to that. But I think men are getting better now, and we do talk to each other.
Absolutely, and it's because of support groups like yours, all of those around the country, that men are beginning to feel empowered to talk.
Yeah.
I always make comparisons with breast cancer.
Mm-hmm.
We are 30 years behind the women and the way they talked. That's why breast cancer is in the position it is now, because women weren't scared to go on television, uncover their boobs, whatever, and talk about it.
Mm-hmm. Well, thank you very much. But I'm sure there may be some other questions. So,
yeah, sure. Sorry.
How this is going to work, I don't know. But here's Mary.
Mary, if you press your space bar, you unmute yourself.
Okay, yeah,
Yep.
thank you.
Got you.
Thank you, Steve. That was a fantastic talk. It really was. If anybody else wants to ask you questions now, we'll go ahead into that. But before we do that, I just want to say thank you very much to Richard Langley, who set all this up, and he's had to learn from scratch to do this.
Well,
he's done a wonderful job. Thank you.
yes, thank you. Thank you. Okay, Mary, thank you very much. Yeah, so any more questions?
A very interesting talk. Thank you very much indeed. You mentioned that wearing a clamp should be limited. What are the risks of wearing it?
It's only just that you're compressing both the urethra and the blood supply to it. So you're
mine more or less full time, because it's the only. Like you, I've had a robot prostatectomy, and it's just devastating. It both incontinent and impotent. Not really worried about the latter at my age, frankly, but I find the only way I can cope is with a clamp and pads, and that works extremely well.
Yep. As long as the pressure isn't too severe, one's always worried about decreasing blood supply to the penis and also obviously to the urethra, because the lining of the urethra needs a blood supply. So obviously you're releasing it regularly throughout the day.
Yes.
And you're not getting any form of, don't get any urethritis or anything like that.
No, it gets a bit sore sometimes, but I mean,
yes,
and if you're very active, it can slip and then you can start to leak. But
yep,
I was offered these other operations, but frankly, I was rather put off by the various risks with them, and I thought I would stick with this sort of rather old-fashioned method.
Yeah, I mean, it's horses for courses. I would seriously counsel you to think again,
Right.
because it's made such a huge difference to me. You need to go somewhere where people do a lot of them. I wouldn't go to a surgeon that only does 2 a year. I don't know where, presumably Birmingham would be one of your nearest centres, would it, Mary?
Yeah. Yes, that's right.
Yes.
That's where all our patients went to for it.
And I think that seriously have a rethink. I was quite worried, Richard, because it's, would you feel it? I'm not aware of it at all. Yes, it's a foreign body. Yes, there is a risk of infection because it's in a dirty area of your body. Or you get 2 incisions. You'll get one which is sort of in the hernia area where they then implant the sphincter. And there will be an incision between basically the anal margin and the very near to the back of the scrotum. That to me was quite painful, I've got to say, post-operatively. A lot of people don't find it as painful. I think my surgeon was a brilliant surgeon, but he did do his knots quite tight. But I was absolutely paranoid about making sure that wound didn't get infected. So silly things like wiping yourself after you've been to the loo, washing properly, just keeping the whole area absolutely crystal clean. But it really has, revolutionized my life. I thought I was coping. I'd take pads everywhere, man bag full of, spare underwear and pads and God knows what else. I never think about it now. I do carry 1 spare pad sometimes in the back pocket, and still there's an extra pair of pants and a couple of pads in the back of the car, but I really don't think about it anymore.
Well, thank you very much. I will definitely do a rethink.
Good.
Because you're young and you're fit. How old are you, Richard?
I'm just coming up for 76.
Yeah, you're fit. There's that's not a barrier.
No.
Any more questions? Yes, Alan? Can you unmute yourself, Alan?
Yeah, can do. I too have an artificial sphincter as well, which is now 6 years old. And exactly like Steve says, it totally revolutionized everything about my life completely. I mean, my story I tell everybody was I was a very keen swimmer, and until the day, and I thought, okay, nobody's going to notice a little leak and what have you. But then I swam one day and they had some sort of dye in the pool, and there was this blue line following me everywhere I went in the pool, sort of thing, until the chap told me to get out, sort of thing. And that was almost the final straw on needing to do something sorted to get it sorted out. Besides all the fact of having these baggy things hanging between my legs and just the general business of pads and everything else. So I would say to you, Richard, as well, really have a serious think about going down the route and have another look at it, because it's night and day. It is absolutely night and day, the difference before and after. And you're right, you don't, Steve is absolutely right, you don't realize, to me it was the worst thing, everything I had to put up with all the other bits, because I had both the operation and I had radiotherapy as well, and I managed to get my hernia nicked as well, so I had to have that fixed afterwards, and I had the sling and that didn't work as well. So I went the whole course all the way through till I ended up with this artificial sphincter, and yeah, just something else altogether. So definitely it is the way to go.
Brilliant. Wow.
Oh, can I come back? Steve, can you send me your card? Because I also had the worry about having a car accident and they trying to catheterize me when I've got it. If you've got a copy of the card you've made.
No, I just copied what the thing that the insert they gave you with the sphincter. But I think having said that, again, I'm not too sure whether it's not lost out of my wallet now. I did think of whether you should have a medical alert badge thing.
You can do your own. You can do your own care management booking. So you can actually arrange your own care management. So if anything happens to you that you can't speak or for yourself, you've got this care management thing. So it's worth looking at that. We've got a speaker coming to talk to our group, hopefully sometime in the future, but I think I might get him to do a Zoom meeting. He was going to tell us how to draw these things up. He works in an hospice, but basically it's just about your quality of life. And if you can't speak or tell people what you like or you don't like, but you could cover it, a problem like that with this, doing your own care plan.
Mm-hmm.
So we'll try and get this chap on to speak as well to us. Bill, did you want to ask a question? Bill?
Yeah. No, I've been extremely fortunate. I think after my prostatectomy, I had a little bit of incontinence, but that went away. And since then, I've not had any problems. I sometimes have nightmares about having problems, like waking up in the middle of the night, wanting desperately to go to the loo, and being afraid that I might have been to the loo first before getting up. And that's about as worst as it's been, I think, for me. So
and hopefully that's what's going to happen more and more in the future, Bill, as we manage to improve surgery and also to get men diagnosed earlier so that they can have much more localized surgery. My biggest fear is that robotic surgery is now a sort of holy cow, that everybody thinks it's the answer to everything. Well, it isn't. Richard's found that. I had an open procedure. He had a robotic. Chalk and cheese, but the side effects do still occur. Yes, I think they're less common with a robotic procedure, but they are not completely got rid of. And we've got to be so careful, I think, that we don't leave those people with side effects on the sidelines. Mm-hmm. That robotic surgery has got to be good because it's new. You've got to be willing to criticize and to look at your results properly.
Mm-hmm. Any more questions? No? Steve, thank you so much for this.
Brilliant. No worries.
Thank you very much.
Really good. And we are going to put it on the website for anybody who's missed it. And if you want to watch it again, you can watch it as many times as you want. I think by Steve's humour and the fact that he's open about what he's personally gone through, it helps a lot of men to actually be able to talk about it themselves. And that's the important thing.
Yeah. Never be afraid to talk.
No.
Excellent, then, Stephen. Yeah, thank you once again.
Well, it must be time for a cup of tea then, guys. It's a shame that we're not in the, was it Kidderminster Town Hall where the bar's open, if I remember. I'm very disappointed.
Sorry about that.
We can always come again.
Absolutely. I'll do anything for a beer.
We'll roll out the red carpet.
Yeah, oh, please.
Anyway, thank you very much.
Anyway, I'm going to leave you. Okay, guys.
Thank you.
Cheers. Bye-bye.
Bye-bye.
Bye.
Okay, bye. Right. Everybody going to clock off now. If anybody wants to talk about the Zoom meeting, how they felt about it, if they found it easy to follow before we close down completely. Did you all cope with it? You could all understand it and you found it helpful?
Yeah, I think we had 23 people altogether.
23. Oh, that's not very good. We sent out about 100 invites, didn't we?
Probably more than, but for a start, I think it was good. But
okay, yeah. I think people are nervous about it. The people are frightened of things like Zoom. It's new, but this is a good way to keep on offering a service to our members. And we've got new members coming through occasionally, that do need help. One's just contacted me yesterday to say he'd had the operation, so he wasn't well enough to watch this today. I said, well, it will be on the website because you will need to watch it. So it is important, you know, to get the information out, especially to new members and even men who've had the operation 2 or 3 years ago, and to really get the support and knowledge that they needed afterwards. So we want to keep on helping people to move on with their lives, really. Well, thank you, Alan, for joining us from the Isle of Wight. That was very nice to meet you.
Very good.
Okay.
Thank you for letting me join your group. And
Yeah,
I don't know what the weather's like up where you are, but it's nice and hot down here. Sunshine, blue skies, blue sea about half a mile from where I live. So
no, it's cloudy.
if you're doing a staycation this year, you might want to think about the Isle of Wight possibly, because it's not too far from you to come across, get yourself down to Lymington and get across, sort of thing, to have a look. But yeah, great to see. I mean, you have to say that when we run these Zooms, we only get from 300, we only get about 25 to 30 turn up each time. So I'm quite impressed with the number that have shown up today for your meeting. I think it's really very good and shows that you're putting the right amount of effort and able to promote it. And of course, it's helpful if you've got a really good speaker, which Steve is. So that really helps.
Yeah, he's an excellent speaker. Yeah. Well, hopefully we'll see you again sometime then, Alan. And I'm saying goodbye to everybody now then.
Okay,
goodbye.
Mary.
Bye, Mary.
Bye. Thanks, Alan.
Bye.
Thank you. Thanks, Bill. Bye.
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 Bye.